But it's my immense pleasure and honor to welcome Dr. Shantanu Shahane. Dr. Shantanu Shahane has been our alumni. He passed out from this very hospital in 1991. So that's more than 30 years ago that he finished his MS Orthopaedics from Sancheti Hospital, and that time this used to be a terrace and the floors were added later, and there have been many get-togethers in this place as we sit on the terrace, and Dr. Shantanu will tell you more about it. But Dr. Shantanu Shahane, very soon after doing 1 year consultant's job in India, he left for UK. He was in Nike Hospital for 2 months and then in Mumbai with Dr. Bowdekar for 8 months, and right away he left for UK, and he's been in UK for last 30 years plus and has developed his way to become a very accomplished shoulder and elbow surgeon. You know, he's one of the renowned faculties there. He does everything around the elbow and the shoulder, including arthroscopy work, arthroplasty work, trauma work, and he's working currently at the Chesterfield Royal Hospital NHS Trust, where he does his pediatric practice, and at Sheffield, where also he does his adult practice. So he's got 2 attachments. He also has his fair share of private practice, and he has 2 sons, William and Greg, who are 21 and 19, and none of them are doctors. So he soon wants to retire. That's what Shantanu tells me, and pursue his further passions. But he's such a busy practitioner. I can bet you that for next 10 years he won't be able to retire, and because the NHS won't let him go. He's got keen interest in academics. He's published in many journals in shoulder and elbow. He's currently the executive committee member of the British Shoulder and Elbow Society, which is a very niche and a prestigious society. And he sits on the editorial board also for this society, for its journal, and has really worked very, very hard from nothing to becoming a very accomplished and a very famous shoulder surgeon in UK. Because when he went there, you know, he didn't have a place to stay. I still remember the day when he went there, and then he staying in a hostel and with some seniors as parasites, and the rest is history. You know, on a lighter note, I remember I visited him after I finished my MS sometime in 94, 95, 95 or 96, and he invited me to his house, and then he made some nice dinner for me, and we had some nice time. We had dinner, and the gas which was lit to heat the food remained on, that heater, and very soon the alarm started ringing, and there was fire brigade below. So we were wondering what happened. Shantanu, do you remember that? So we were scared, but then fortunately it wasn't much of a trouble. Otherwise it would have been a big issue for Shantanu, not for me, because I was just visiting. But Shantanu, it was a nice time. I still remember those memories. Even in Sancheti Hospital, he was my senior, and we welcome you today to talk to our boys. We now have 20 MS students every year, so 3 years will make it 60, and they are all interested to hear you and also know from you, you know, how to really get the most in your residency, and then what are the future avenues open if they have to travel to UK or USA or Australia, because I think these are the 3 countries which are probably easily accessible, and you might be able to guide them on how they could come to UK and what are the ways and means to come to UK. So if in the end you could talk a bit about that, that would be nice. So please join me in welcoming Dr. Shantanu for today's lecture.
One of the extremely brilliant students we had is really, and he used to work a lot, and it's always complained, "He कोई appreciate नहीं करता है यहाँ पे." I will remember it. But those were the days. We were very few. We were just 3 per. Shantanu, 3 per unit.
Yeah.
3
The
CR,
nine residents, 3 in each.
In the whole hospital, 9 residents.
9 residents in the whole hospital. So those are probably the people who are there in the unit actually. We've got more people than that. So those are the days. You know. And we had a lot of work. We used to do some emergency OT there. नीचे एकदम जहाँ basement है, there used to be an emergency OT there. तो रात को वहीं पे केस करके वहाँ पे निपटा देते थे कई. Good times. But times change, technology change. And you must still remember there were times we didn't have the CM at that time. It had just come new. So very few patients we would do under CM, rest we would do under X-ray shoots, AP and lateral. Imagine that.
And we used to wait while it was being developed. And then if your guide wire is in the wrong place, you again reposition it, and then you take another lateral X-ray, and you wait another 5 minutes.
So the first X-ray, AP lateral, AP is excellent, lateral everything is out posteriorly. Next X-ray, AP is out inferiorly, it is out, lateral is good. So in the end you juggle, you know, and then you find. Today it is so easy for you. You shoot AP lateral, say where you want to go, and you can continuously shoot and go where you want. Those were not the days that time. And even before that, let's see somewhere Sancheti didn't have that issue. X-ray lena hai nahi lena. I remember doing my house jobs in Delhi and all that, and every emergency we would get 30 chips. That means 30 cards to take an X-ray. If you had more patients than 30, you can't take an X-ray because only 30 chips are allowed. Because X-ray plates are very expensive. So those are the days we used to you have to make up your mind X-ray कराना है कि नहीं कराना. और अगर ज़्यादा ऐसा नहीं लग रहा है, थोड़ा प्लस माइनस लग रहा है तो मत कराओ X-ray क्योंकि X-ray chip is gone. So those are the days. From that you have come down. You not only take that X-ray, you take one joint above, one joint below. Not to miss anything. Hey, that is not to miss anything. So imagine the amount of things we missed at that time. So from those days we have come to the technology is really become. अभी तो X-ray क्या सीधा digital shoot करता है और वो दिखाता है यार उसमें. What lovely days. Fantastic. But listen to him. How
Thank
it
you.
is.
I want the man himself to speak to us about shoulder evaluation, examination, and other things. Over to Dr. Shantanu.
Which one? Ladies and gentlemen, good afternoon. Firstly, Parag, thank you for your kind words. Dr. Parikar, thank you for inviting and hosting and your hospitality. And thank you for all of you giving time to come here. We could have spoken about a lot of things. We could have spoken about revision shoulder replacement, we could have talked about arthroscopy, cup repair, lateral jet, etc. One thing that is going out of the system in the world is people first look at the MRI scan and then ask people the history. And we are going the reverse way in UK. I think you must examine a patient properly first and come a differential diagnosis and don't lose your basics. It's so fundamentally important. And it's only when you get this right. So we have now started doing this on a regular basis, and we go around the world in FRCS Ortho exams, on examiners, in mock exams, international FRCS Ortho, and we are concentrating on basic examination techniques. You don't look at the X-ray first, make a diagnosis, and then say, "Aapki umar kya hai?" You know, you start in the reverse way. So I hope at the end of this day you will have a little bit more insight into shoulder examination. I've done this now for 18 years, and most of the UK graduates now follow this process of examining the shoulder joint. This afternoon is divided into a couple of sessions. First was going to be examination of shoulder joint. Second was going to be a little bit of a light-hearted look at our days in SIOR, and we have some nice pictures to show. It's a pity Rajiv Arora is not here, but Arora sir, if he was here, he would have enjoyed some pictures. But I know Parag and I think Rajiv have to go, so I've just flipped the presentation. I'll show you the light-hearted bit first, then we will talk about the shoulder examination. At the end, I'm open to you. All of you can ask me whatever questions you want. If I know, I will answer them. I can't see anything without specs these days. That tells you you're in proper middle age. So these are the two hospitals I work at. That's on the left is the Chesterfield Hospital. It's not a tall hospital. It's basically a spread out hospital. It was made in a green field. And my office is somewhere down there. It's about a 700-800 bedded hospital. That is where my pediatric adult practice is. And for the last 10 years, I've been working at Sheffield Children's Hospital. When I was doing my MS, Prof. Sharard's Children's Hospital book was world famous. And I said, if I can ever even work in Children's Hospital, that would be great. To get a consultant job in Sheffield Children's Hospital, which is an absolute premier hospital in the world now, I feel really privileged. So we do my pediatric practice over there. I think I'll just give you a brief biodata. Parag has very kindly mentioned a lot of things. I'm from BD Medical College. In 1983 I joined, and then I joined MS Ortho in 89. passed out in 91, got the result in 92. Then I did DNB while I was in Hinduja Hospital with Dr. Baudekar. And luckily, I got into double sponsorship scheme. So I did not give plan. Can I tell you that I would have never passed plan? It has so much medicine in it, and I was so far away from medicine. So if double sponsorship scheme wasn't there, I wouldn't have gone to the UK. So I'm really pleased that it existed at that time. And then we joined the registrar rotation. In orthopedics, there is a 6-year rotation program in the UK. You have to go through all the branches, pediatrics, spines, arthroplasty, and so on. And at the end of 4 years, you give your FRCS sort exam. 5th year, you finish the remaining modules. 6th year, you do a sort of what you are interested in, arthroplasty or sports medicine, and then you do fellowship. So it's a 7-year program before you become a consultant. I did MCH in Liverpool in 97, and then FRCS 1, 2, and finally FRCS 3 in 98. And then we went on fellowship to Wrightington Hospital because the primary place, John Charnley, started his hip replacement in Wrightington Hospital, you'll be aware of that. And then went to Dublin. I had a young family by that stage, and therefore I couldn't go too far in the Republic of Ireland. And then got a consultant job in Jan 2002, so it's nearly 22 years now. You realize in the UK, when you get a consultant job, your learning starts. You don't stop learning, you actually start learning. And you realize that when there is nobody whom you can look up to, you think, oh my God, I don't know half of these things. And therefore, you then start doing fellowships. And I was very lucky enough to get these 3 fellowships. So I went to Joe De Beer, who's absolutely the best shoulder surgeon I've ever seen. He operated on Rahul Dravid and many of the top international rugby cricketers. And I spent a few weeks with him, then went to Houston to visit Gary Garsman and Sean Driscoll. I'm sure all of you have heard of Mayo Clinic, everybody's aware of him. And I spent a few weeks with him. And it was priceless because that consolidated my knowledge of what is going on in the world and how to get better. And eventually, once that was done, in 2012, I got this prestigious Children's Hospital consultant job. You will also realize in the UK that clinical medicine is only one part of your job. That is something you get used to. You go and you do a replacement arthroscopy after 10 years. It is these non-clinical activities that decide how good a person, how high academically you can reach. So like we have Indian Orthopaedic Association here, we have the British Shoulder and Elbow Society. So I've been on the education committee for 4 years, the executive council for 4 years, and then we started something called the instructional course. The instructional course is like a revalidation course, a 4-year program in which you cover every aspect of orthopedics. I was the only person from District General Hospital who was appointed on the panel and eventually appointed as chairman. So I was privileged compared to what I was when I started. As Parag has said, I went to UK with minus 300 pounds, no airfare, and no money as a clinical attachment. So I was quite pleased with these achievements. And then obviously I'm a shoulder and elbow editor. I work for a few companies. They pay me separately, DPUs with a nephew and Acumen. So I go wherever they want me in the world. I have to put that as a disclaimer because that's a conflict of interest. I use their implants. DPU is arthroplasty, with a nephew is arthroscopy, and Acumen is trauma. So after 10 years of working with them, I'm on their consultancy paid agreement. And finally, as I said, your learning never stops. You continue learning. So then I went to St. Louis, Missouri for another Escalab fellowship, and Shoulder and Elbow Society sent me to Nagoya to represent the shoulder and elbow surgeons in 2014. And then we have started new roles, and this is where I'm going to concentrate when I leave clinical medicine, is teaching. And that's one of the reasons to reconnect with all of you. FRCS or the international exams, British Orthopaedic Association. And for my sins, I have taken that job, which is all-consuming job. We have started a group of private surgeons, 60 of us, who have joined the private practice consortium. And I have become medical director of that. And that is hard work. Trying to manage 60 orthopedic and general surgeons is very difficult. Everybody have their own egos and ego hassles. So, but that is something new. It's not something I have trained for myself. And finally, I'm hoping to retire from NHS practice in 2026, but as Parag says, I don't know if this will work. But nevertheless, I'll continue with this. Good. So let's look at some memories of SIO. As I said, this was going to be the last slides, but I think you'll recognize some of these people. So believe it or not, that is me there on the left side. And that's Rajiv Joshi. I don't think anybody of you here will know Sumer Singh. Sumer Singh was a really excellent spinal surgeon. He was a great character, a great friend, as Rajiv will vouch to, but he's gone off grid, as I've just been told. So we really don't know where he is. And that's me. We were pretending, all of us had a few drinks, as you can understand, we were pretending that we were jumping off the top of Sancheti Hospital. And how would you do that? And so all of us had pictures of each of us. and Rajiv was taking pictures of us. So there you go. This is one of the camps. That is Ashish Diwan, that's Rajiv Arora, that's Rajiv Joshi, that's me there. That's Vivek Jindal, my colleague who sadly passed away 2 years ago with chronic illness of some kind, the details I don't know about. And after finishing a long day at polio camp, we went to a little guest house, and this was just a picture outside the guest house. So those are amazing memories. This is 1990. I'm fairly certain some of you were not born, but nevertheless. This is interesting. So we were making Dr. Milind Gandhi have his first cigarette, and Dr. Arora was the initiator. So as you can see. So it was good fun. He was pretending to be a Western cowboy with the hat on the top. So it was fun times. And this is us dancing there. That's Paul I was telling you about. Nat Gorkor. Yeah. So he was our canteen manager at the bottom. I don't know how many of you know Amit Chandratre. Amit is in the card. He's my junior. That's me there, and Milind's there. So it was good times. It was very good times. The next slide is important, and I think as I'm getting older, I've become more philosophical in my life, and I've realized I don't think you need very much in your life. A little bit of health, happiness, a little bit of money to continue. But I think the most important thing, I think you all will understand, as you're starting in new careers, you will go through many exams, many ups and downs, maybe in this country or abroad, but you will have lots of obstacles. And the one thing that has kept me going is my family. And that to me encompasses everything. And that's my wife, Angela, and those are two of my boys. And without her, I wouldn't have achieved anything. She's been an absolute rock behind me at all times. She in fact gave up the job just to help me. This was, we were on a holiday in Budapest. And my eldest son is on the right side, William. This is in Copenhagen, he's doing his law in Copenhagen, and that's great. So they keep me going at all times. And I'm sure you'll realize that when everything goes wrong outside, you need to come home to an oasis which is peaceful. Achieving a lot of money will not get that. So I think it's an important message to give. Finishing that, we should start with the academic part of it. Okay. This is my examination of the shoulder joint. Okay, and it is in various colors, and there is a reason for it. And each color will have a reasoning behind it. And I want you to come back and tell me simple diagnosis what you should do. Okay? Can I have a volunteer? Anybody? Anybody? I won't make you undress. Don't worry about it. No? Yeah, thank you. Thank you. So, that's very kind. That's very kind. Just take the paper off. That's all. So, examination of the shoulder has to happen from all sides. And one of the reasons you fail in your exam is if you don't go behind if you don't go behind the shoulder. So, what I say is you have to look from the front, you have to look from the side. So just come here. And you have to look on the side. So, axilla is something I have to here. Axilla is like the popliteal fossa of the knee. People don't turn the patient over, you miss a lot of things at the back of the knee. But axilla is general surgery. So you must look. So what am I looking for from the front? I'm looking for the contour of the shoulder. I'm looking at the obvious things like clavicle malunions, sternoclavicular joint dislocation. Then I'm looking at the side. I'm looking for arthroscopy scars. I'm looking for the deltopectoral scar, which is the commonest thing. And when I go behind, I'm looking for spinal alignment, and I'm looking for wasting of the rotator cuff muscles. And sometimes that's all you need to come to a reasonable diagnosis. And you will see why I say that. If you look there, that's all you need to see. So you look at the first person and you think, oh, there's something wrong with his ACJ. You won't come. Are you? Is she? Let's come this side. Yeah. So if you look at the first picture, patient walks in and he points to the top, and you know there is something wrong with his AC joint. On the other side, you look at it, what's wrong with that? Pointer. The contour of the shoulder on the right side is flattened. He walks in and you should say, ask him, he's had a dislocated shoulder, he has got a complete axillary nerve palsy. His deltoid's not working. You don't need it. That's a malunited clavicle. When you look here, look at the wasting of the infraspinatus and the supraspinous fossas. You know this guy mostly has a cuff there. That patient was standing like this for the whole of their FRC assault, and they never went to the back. And they missed the scoliosis entirely and completely. The patient, the candidate failed. Because they were told to examine the shoulder. You're never told to examine the shoulder, you're asked to examine the patient. That is so important. Palpation is not that fundamentally important in shoulder. The one point that is very important is the AC joint. So as you move your hand over the AC joint, feeling that, to me that tells me that this is non-tender, there is no major AC joint pathology. But you can palpate the rest of the stuff if you want. Thank you. And confirm the findings of the inspection at that time, okay? Now comes the range of motion examination. This is really important. Just stand before me. In exam, you will struggle. People say all kinds of things. Can you do some flexion? Can you do some abduction? The patient has no idea. So the best thing is to ask them to do it. Put your arms out. Lift it straight up in front, as high as you can go. And that is your flexion. And then you compare active and passive. Come down and sideways, and you go up and abduction. Okay? The next movement is the single most important movement, external rotation. So, this switches on. Okay, if somebody says, what is the one thing you would do in the shoulder examination? Nothing else, you're not allowed to do anything. You're a GP working. You tuck your elbows in, here, and ask for external rotation. And if he has 60 degrees of external rotation here, he has 10 degrees of external rotation here, there are only two diagnoses this can have. Any idea? Number one, or? Frozen shoulder is adhesive capsulitis or osteoarthritis. In the absence of a traumatic condition, which is locked posterior dislocation, in the absence of trauma, as soon as you have reduced external rotation, you have only two diagnoses. Now, if this gentleman has full external rotation of 70 degrees bilaterally, he does not have a frozen shoulder and he does not have arthritis of the shoulder, bleeding human inflamed. Okay? And how do you distinguish between the two of them? X-ray. You have, and therefore the diagnosis of frozen shoulder is reduced active and passive range of motion with a normal X-ray. That's mandatory. You cannot diagnose a frozen shoulder unless you have that. And age, of course. So if he's 30, he's more likely to have frozen. If he's 70, he's more likely to have arthritis. Okay. Then we come to, and then you're doing flexion and abduction. You're ideally supposed to go at the back and look at the scapulothoracic rhythm also. Test all movements actively and passively. This is Nanette Oaks. Nanette works with me as a physiotherapist. I couldn't do my job without Nanette. So she's an extended scope practitioner, and all my complex rehabilitation needs go to Nanette for sorting it out. So that's flexion, abduction, external rotation. Why do you lock your elbows in? This is really important. You can't do this because you isolate the humeral movement from forearm rotation. So when you do pronosupination, you don't do this. Here you have no idea whether it is the shoulder rotating or whether it is the forearm. So you lock your elbows in. This is pronosupination and this is humeral rotation. So locking elbows in separates the forearm from this. These are very simple things that you need to learn. There is no point in doing a fantastic cuff repair if you don't know these basic things. So the next thing is internal rotation. What is a true internal rotation? This is true internal rotation. Okay? When do you use this movement? Never. Therefore, what you need is a functional internal rotation. What is functional internal rotation? A bit of extension. Okay? Flexion of the elbow, internal rotation of the shoulder, hyperabduction of the thumb. Because that's where women reach their bra straps, women reach their toilet habits, and so on. So this is called FIR, functional rotation. So get out of the habit of saying the patient's internal rotation is to posterior superior iliac spine, L5 L2. Say his functional internal rotation is to wherever the thumb, extended thumb reaches. So try and incorporate that into your practice. Okay, so what have we done? We have stood the patient. The entire shoulder examination happens in standing position. You have to expose the extremity. So in the exam, you will fail if you don't say I have to expose from here to here. And the examiner will say, don't worry, carry on. We have made the patient stand, we palpate it, we have done range of motion. Now the impingement test and examination of the cuff. Okay? So there are three impingement tests. One is the Nias sign, Hawkins test, and scarf test. Okay, so what is Nias sign? All these three things are passive movements. When you get a painful arc, that is not Nias sign. You have to do it passively. How do you do Nias sign? Hold the scapula with the arm internal rotation. Why internal rotation? Everything has a reason for it. That means you put the greater tuberosity underneath the coracoacromial arch. And then you lift the arm in the plane of scapula till the patient experiences pain. That is Nias sign. Okay? Then you keep your hand here, get it here, bend it. That's Hawkins test. Then you keep the arm here, put the elbow here, press this, pain on ACK, scarf test. So in one simple smooth motion, I will show you again. Nias sign, Hawkins, and then you will have pain. You're trying to rub the great rotator cuff underneath the acromion ligament arch, put it across, press here, pain on ACJ, scarf test. Is that okay? Passive. All three are passive. And then this is important. If the patient has this technique, if the patient has a positive Nears and Hawkins, you are all aware of this. You give some local anesthetic in the subacromial space, pain goes away, diagnosis confirmed. That is Nears test. So that's Nears sign, Hawkins test, scarf test, and Nears test. Don't mistake them with each other. Okay? Then we complete this. So this is Nears sign. I'm doing the first is Nears sign, second is Hawkins sign, and the third is scarf test. Remember, please, in scarf test, the pain has to be on ACJ, not generalized pain. When I do that, it shouldn't be low arm, it should be a high arm scarf test, and the pain has to be on ACJ. Without it, it's not positive ACJ. In the exam, if you ever give FRCS or especially international, and we'll come to that how you can apply for that exam, the rotator cuff examination is really important. And the two prerequisites for cuff examination, you have to abolish pain and you should have reasonable range of motion. How do you abolish pain? By giving injection, local anesthetic. Are you aware of these tests? Everybody of you will be at a different level of learning, junior and senior. Supraspinatus test, either empty can or joke test. What I don't want you to do is to just do the test. I want you to know the reason why you're doing it, okay? Let's turn it towards me. So what do we do for supraspinatus? We put the arm out 60, 70 degrees, turn internally. Why internally? Because supraspinatus is always masked by the deltoid. Agree? So when you rotate internally, the deltoid comes here, whereas the supraspinatus comes in straight line. So you're putting the deltoid at maximum mechanical disadvantage, and you're putting the supraspinatus at maximum mechanical advantage. You can't completely separate the two. And then you hold it there and you push down, push up as hard as you can, as hard as you can. That is an intact supraspinatus. Does that make sense? So you're trying to eliminate the deltoid from the supraspinatus as well as you can. The next we are interested in infraspinatus, teres minor, and subscapular. They can be done again like they in one nice smooth motion. What does the infraspinatus do? Infraspinatus is an external rotator with the arm by the side. Agreed? So when you are here, I'm going to push it inside, try to stop me. Push out, push out, push out. That's intact infraspinatus. Okay? Similarly, I will then take the arm here. Teres minor is an external rotator in abduction. So I'm going to push it, try and stop me, that's teres minor. If it doesn't, the arm comes down, you have hornblower sign positive. Left side, hornblower side. And while you are at it, you take the arm behind, turn down for me, and push the hand away from me. Push the arm away, push it away, push the hand away, push it away, and that is subscapularis, that is the lift off. What's happening in lift off test here? The subscapularis is rotating the humerus internally. If the subscap is gone, as he tries to push the hand away, the humerus rotates externally. So what does he do? He will do this, flexion of the wrist. So if you understand the biomechanics as to why these tests are working, you will not go wrong. Making sense? Okay, so supraspinatus, arm as for 70 degrees internal rotation, reduce the deltoid function, push here, not here. Why? If you push here, the triceps compensates. So you want to push above the elbow, push up, so you've eliminated triceps, so eliminated deltoid. You're checking supraspinatus in isolation. Okay, infraspinatus is lax sign, hornblower sign, teres minor, and lift off sign. So you've just kept your hand in one place, and all three things have been done together. So this is the empty can test, which I have told. Supraspinatus, that's the lax sign, that's the hornblower sign, lift off test, and you're aware of peripress test. So if the arm can't go behind, you put the arm in front, elbow out, internally rotated, push this, and what's happening here? Subscap is internally rotating the arm. If it's not working, this will just not come up because the humerus is externally rotating. Am I making sense? It's really important to understand the biomechanics because we are not medical students. We have gone to a higher level. And we need to know exactly why we are doing something. I won't go into the details of this. This is mainly comes from the brachial plexus examination. But all of you should be able to examine 3 muscles from the front deltoid, pectoral, the lat dorsal, and 3 from the back, rhomboid, serratus anterior, and trapezius. If you don't, then you will brachial plexus examination, you will fail. Slap lesion. Everybody's aware of what's a slap lesion? Yeah? Anybody doesn't know slap? You can say yes. I didn't know it at the stage, but nevertheless. So slap lesion is where your biceps tendon attaches to the superior tendon and it comes off. There is no specific test which is absolutely accurate. O'Brien's is fantastic. And that's the only test I will do. So what do? 90 degrees flexion, 15 degrees adduction, internal rotation. Now, if the bicep, and then I'm pushing it down, push up, and he has pain? No, okay. So if he's in pain, then what is happening? His superior anchor of the biceps is not attached. So what happens? The biceps is trying to fall over the lesser tuberosity. Agree? And that's why he's in pain. So what do you do? The second part, that's really important. You turn it outside. So what happens? The biceps goes back and relocates in the groove. So it's now not dependent on the superior anchor for stability. Now I push it down, push up, no, not bending, keeping it straight, and push up, and the pain goes away. Am I making sense? Both things are really important. Arm straight in front, adducted, internally rotated. Pain, the biceps is trying to fall because it's not attached. You relocate back, it's not dependent on the superior anchor, falls back in the groove, pain goes away. Both parts positive, you have a slap lesion. And you will get a very classic history from a slap lesion person. You'll be a rugby player who's tackling the next person and he suddenly moved the shoulder in an extended position. A cricketer who's throwing a ball from the boundary and says, oh, just threw enough and something pop. 20-year-olds don't get cuff tears. His biceps anchor is up. A weightlifter who's suddenly lifting, he comes to your clinic and says, I was lifting something, a sudden pop in the shoulder. And that is your slap lesion. A young patient who has an isometric contraction of the biceps will either rupture it here or he will take it off here. And that's the first part, and that's the second part. Speeds and near-distance are very exam-oriented tests, therefore biceps tendinitis. Bend it here, bend here, and bend it towards it. Yeah, and that's biceps painful here, and if you turn it outside, supinate, and lay it in front. So speeds and near-distance are the most non-specific and non-sensitive tests for biceps tendinitis, but it's a historical test, and therefore the examiners like to know about it. So, where are we? We have stood the patient, we have looked, felt, and moved. We've done the impingement test, we have done the cuff muscles. Now we come to instability testing. In the instability testing is the only time when the patient has to be in a lying down position. In the FRCS or the exam, you don't have a couch for shoulder examination. So please sit down and you tell the examiner that I need a backrest. Why do you need a backrest? You need the shoulder blade to be stabilized. Okay? So what do we do for instability testing? You need to do some generalized ligamentous laxity. Everybody is aware of Baton's score. So for your MS Orth, you must know Baton's score. You must know that 5 or more is hyperlaxity. These are very basic things, and I'm sure you are aware of this. Sulcus sign is a very simple sign. It indicates laxity. So if I just hold it like this and just relax, and I pull him down, if I get a little sulcus, that is laxity. Laxity, he may have sulcus positive, but some of you, there is nothing wrong with that. It's a normal collagen that you have. Okay? Load and shift, I won't go into that, but apprehension relocation is very important. So this is your sulcus sign. See how subtle it is. Just the tiniest of the subtlest of the sign you get in. It doesn't have to be a frank sign. So that is the sulcus sign. And then you come to these 4 stages of apprehension. So what's happening is, this gentleman had a shoulder dislocation, anterior. And he's come to your clinic, and he says, every time I go for a seat belt, to put on a seat belt in my car, I don't feel my shoulder is stable. What is he doing? He's doing an apprehension test for you. He's doing it in a clinical scenario. You don't need any more examination findings. You need a specific examination to do. So if you've asked his age, he said, I'm 22 years old. I was playing cricket, and while taking a run, I fell down. I dislocated my shoulder, went to the A&E, was relocated back. Everything's fine. I've got full movement, but I can't get my seatbelt on. Or if I'm sitting in the passenger seat and I go for the briefcase in the back, oh, I feel something is wrong. Answer's there. He's done the clinical test for you. What is the test? Apprehension. Abduction 90 degrees, external rotation. And he said, oh, no, I don't like it. If it's a subtle apprehension, you have to do augmentation. That's what I'm doing there. First one, augmentation. If that doesn't work, what do you want to do? You want to relocate it back. Push it back, patient is much higher. Okay, so that's apprehension, relocation. Why is that happening? Because the patient has a soft tissue bank cartilage. His inferior glenohumeral ligaments are gone. So when he goes there, the humeral head just subluxes. Remember, the shoulder is a very complex joint. It's like a golf ball on a small tee. It's a very, very complex joint. It's 5 times the size of the tee socket. And therefore, it's an unstable joint. And on top of that, God has given you some of the most powerful muscles, the deltoid, the pecs, the traps, and the lats. So you have an unstable joint with powerful muscles. It cannot work. So what has nature done? It has created the labrum. So labrum increases the depth of the glenoid, and then it has put rotator cuff muscles around it. to give it stability. So rotator cuff gives it dynamic stability and the labrum gives it static stability. When you have a shoulder dislocation and the labrum damages, your ligaments become dysfunctional. They leave a gap there. All of you are aware of this. You have all seen bank card repairs, certainly. And that's why you are repairing the bank card to increase the depth, but more importantly, you are making the redundant glenohumeral ligaments back to a functioning state. Posterior instability, which is jerk or Kim test, that's not often seen. When do you see posterior instability? Has anybody of you seen a posterior instability? When does that happen? So that's very exam answer. Very true. Very true. The kind of how I see posterior instability is epilepsy. But remember one thing, this is a very important statement. If you take 100 epileptics, the majority of the dislocations in them will be fabulous. But if you take 100 posterior dislocators, the majority will be epileptics. Fantastic. That's great. It takes the ages to convince this to people. So this is fabulous. So don't think that because you have an epileptic patient is anterior instability, it is mostly anterior still. But if you take majority of the posterior dislocated epileptics, sometimes I see this in my practice in boxes, juvenile boxes, where they're trying to duck and avoid and they get directly hit from the front. Thirdly, sometimes when they fall, instead of falling like this, they fall like this in the front. Those are bikers. So where I live in Derbyshire villages, we have lots of mountain biking trails. And when they come off from their bike, the first thing they do is like this, and it just goes posterior. They don't fall like this. When we slip, what happens? We just go like this. And that is their anterior dislocation. But in bikers, they go in front like this. So I sometimes see them. Electric shocks is a very good exam answer. I've never seen one. Epilepsy, traumatic condition, direct anterior blow. So for that, what we do, that's a difficult one. Because remember, the glenoid is antiverted like this. So posterior is on. So what I do is come out from this and go like this and push it back. Posterior instability doesn't manifest as instability. What does it manifest as? Pain. Slap lesions don't manifest as instability. Pain. The patient says something clicks in my joint. That is slap, biceps. Posterior instability says as soon as I go up for something, I feel something is not right. That's because the human head is trying to get out of the back, but because of the version of the glenoid, it doesn't allow it to come out. But it is just damaging that little labrum at the back. So that's the Kim's test, and you have a jerk test. So Kim's is for back, and jerks is for the sort of 9 o'clock position, and Kim's is for the 7 o'clock position, depending upon which part of the labrum is gone. So you've done most of the things. Last bottom thing there. Always screen the cervical spine. I'm not a spinal surgeon. But when somebody comes to you and says he has pain in the trapezius, this could be referred pain from the neck. It could be referred pain from the shoulder. What is the main nerve that supplies pain fibers to the shoulder? But nerve. Suprascapular nerve. It is not the axillary nerve. Suprascapular nerve supplies 75% of the pain fibers. 20% axillary nerve, and then the rest, according to Hilton's law, any nerve that passes by is a small fiber. Therefore, when you have pain in the shoulder, cuff tear arthropathy, you do a procedure called suprascapular neurolysis. You take the nerve away because the motor function is gone anyway of the suprascapular nerve. The cuff's not working. So it's doing the bad things. So therefore, suprascapular nerve is the main supplier of pain to the shoulder. And therefore, the C5 is here, C5, 6. You're right. That's the root value of suprascapular nerve. You have to be careful. How do you distinguish neck pain and shoulder pain? We'll come to that in a second. But if you think it's subacromial pain, so inject local anesthetic. When the patient comes back and says, half my pain is gone, half the pain is shoulder, half is neck. 0% gone, everything is coming from the neck. So always remember that. I won't go into spurring and nerve side. I think a spinal surgeon will teach you better. And finally, these are rare ones. Sometimes people come with this very unusual symptom. They say, doctor, my hand goes blue sometimes. I just feel it's cold, it's numb. I haven't had any traumatic condition. And you may have a cervical rib. And it's rare. One day when you pick up the cervical rib, you'll be really happy. Because it gets mislined this, because it is not a common thing present. How do you do cervical rib? You basically abduct, extend, feel the pulse, look towards me, take a deep breath, and hold it there. What are you doing in all of this process? You are thinking. You are reducing the space between your clavicle and your first rib. That's where it goes through. So the lung is expanding from the bottom, and you are really reducing the subclavicular space. So if there is a latent fibrous band or cervical rib, it starts creating problems with your pulse. Not the greatest test. But if you feel there is something I can't understand, everything looks okay, get MRI of the brachial plexus. Because there you will see compression of the neurovascular structures. I've only diagnosed 3 or 4 in 21 years, but it's a real achievement. Everybody's missed that. And they go from surgeon to surgeon to surgeon. Everybody thinks you're mad because there's no structural problem here, but there is. Bruce test is a neurological component. Basically, put the arm here and you do this repeatedly. I think this test, I have never seen it positive, so I have no idea why it's there. But for the exam, they ask you Bruce test, your neurological component becomes obvious. Never forget the exam, same side, wrist elbow, opposite shoulder, neurovascular function. The last thing is really important, and I teach this to everybody, the simple shoulder test. So if a patient comes to you and he can do these 4 things, 1, 2, 3, and 4, he doesn't need an operation. If he's doing these 4 things painlessly, so he can lift the arm clear, he's eliminated your painful arm. Okay? He's taken away impingement syndrome. If he can come there, he's taken the cuff tear off. If he can reach opposite, he's taken ACG out of the picture. Scarf test is done. Agree? If he can do this and come out, he's already confirmed subscap is okay, and he has no frozen shoulder. And if he can reach here, he's taken away your apprehension relocation. He is not an unstable shoulder. So this simple surgical shoulder test is really useful. I tell this to all the GPs. Guys, don't send me a patient if you can do these 4 painlessly, because it doesn't matter what investigation I'm going to do or what I'm going to find. He doesn't need me as a surgeon. So the simple shoulder test is very, very useful test to do. So when you're examining the shoulder, make the patient stand, expose the extremity. Look, feel, move. Then do impingement test. I show you Nares and Hawkins in 1 sweep motion. Cuff status, supraspinatus, infra, teres minor, and subscap, all in 1 motion. Other muscles, we talked about 3 from front and 3 from the back. Subdivision O'Brien's test. First stage, second stage. Remember the reason for it. Instability, sulcus sign, Peyton's hyperlaxity score, and apprehension relocation. Don't forget the neck. Don't forget the cervical. There was one patient who came to me who had pain, and I put him on the waiting list, my own mistake. And when he came for the pre-assessment, he said, "Doctor, my pain is gone completely." I said, "Why?" He had a cholecystectomy. His gallbladder was taken away. Referred pain. Don't forget where pain can come to the shoulder for me. He said, "I'm completely pain-free." He was going to have a shoulder arthroscopy. Diagnostic, because I had no idea what to do. He never told me he had gallbladder problems. So referred pain from abdomen, from neck, from thoracic rib. So don't forget those things. Always examine neurovascular status. Most simple important test, external rotation. Because it takes away 2 diagnoses straight away. ACJ pain gone, no pain, you have eliminated ACJ, you have taken frozen and osteoarthritis out of the equation. If it's a young patient with trauma, you know it's unstable shoulder. If it's an older patient with trauma, you know it is a cuff tear. It's not difficult. But as long as you think about it, the thing is not a simple shoulder test. That's a very, very simple test. So you can tell your GP friends, when you go and practice anywhere in India or anywhere, tell your GP friends, guys, ask him to do this, 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 and this. And if there is no pain, he does it freely. He's not hitching his shoulder and he's not doing it. There is nothing major going on. He may have a problem. He may have a partial cuff tear. He may have mild impingement, but he doesn't need me necessarily. Okay? And in England, it's the same problem. Clinics are busy, so people do exactly what they have to do. They look at the X-ray, have a very quick chat, and get the patient out, and then you tell them, "You've not done a full examination." "Oh, wow, Mr. Shahane, I'll do it." We're not called doctors there, by the way. It's a real insult to be called a doctor for a surgeon. I'm sure you know this. So all surgeons are called Mr. Shahane or Mr. It comes from the surgeons being butchers. The butcher in the village used to be called Mr. And the surgeons were just glorified butchers. So when you get your FRCS, you become from doctor to a Mr. And that is the real rite of passage. And if you're a doctor, you're not a surgeon. So it's a very interesting concept, but nevertheless, that's besides. You have to do this every day in your clinic. Because without which, you will revert back to how you do your test routine. If it's a very quick assessment that you do in your clinic because of Dr. Sancheti is shouting at me, "You only see 2 patients, you only see 3 patients, I've got 20 to see, what are you doing, you useless person?" So what are you going to do? Oh, MRI, this is get the patient out. You are getting in the boss's good books because you are seeing a lot more patients. But that will not allow you to do this. So in your mind, this should be clear in your head. You can skip some steps, but this should be continuously in your mind. And you have to practice on yourself. So our residents go through the same process. I tell them to go into batches before the FRCS or exam and practice on each other like I was doing here. Practice, practice, practice in clinic, practice again. And then you get that. Good, thank you. Thank you. Any questions on examination first? Do you do any shoulders? When I was here, I did hardly any shoulders or elbows. It's a very niche specialty. Everything was trauma or joint replacements, knee arthroscopies, lots of polio cases. Dr. Sancheti used to do a phenomenal triple arthrodesis, KHS. But I don't think I saw a single shoulder arthroscopy. I don't think I saw many. I saw a lot of humeral platings and distal humerus, that we see. But no shoulder replacement at all. Zero. And this is something that has come on in last 20 years? And I'm now 30 years in the UK, so I've never seen anything like that. So do you see a lot of shoulders here?
Yes.
Arthroscopies?
Yes.
Cuff repairs?
Yes.
Who does it here?
Yes.
Okay. So Ashish Babulkar was 1 year junior to me, and so I'm meeting him tomorrow. So he's working in the foundation. So we talked a lot about the same panels on most courses and so on. So we learned in the same place in Wright Newton. The same thing, like I gave you that example, just follow a process. Don't be haphazard. Because if you are, all your life you will do the same mistakes, and one day you'll be missing things and missing things. Questions on the clinical examination first. If there are no questions, it means either you've understood everything, or I have been an abject failure. Okay, good. Any other questions about anything?
What's the current scenario of treatment in
Current-
shoulder?
Yeah.
Treatment. There is a dilemma to in inflammatory phase, some consultant give physiotherapy, and in inflammatory phase, some physicians give rest. So
Give
rest, not
rest.
physiotherapy.
No. So the treatment in the early stage is over. So say if the classic patient I have is a 42-year-old lady who says, Mr. Shahane, I woke up with pain, acute pain 3 weeks ago, 4 weeks ago. No trauma. I can't move, I can't sleep, disturbed night pain. Nothing works. I'm taking analgesia, I'm on codeine, and so on and so forth. In my mind, I'm thinking this lady has frozen shoulder. Then she will tell me, oh, doctor, I'm also hypothyroid, I'm also diabetic. Middle-aged lady with hypothyroidism, diabetes, spontaneous onset, night pain, non-traumatic. In my mind, it is frozen shoulder. I have to be really prone. So what do? I examine. You can't examine much because she's in pain, she won't move. What do? Just do this. Okay? Distribute. Maybe painful, but it is still distribute. Then I get an X-ray because the other diagnosis is? Yeah, but what else is there?
Yes.
Very good. So calcific tendinitis comes like this in acute, but that is so bad, they come like this to their knee. It's like either septic arthritis is the diagnosis of calcific tendinitis. That's what they come. And you transform their life by giving subacute injection. So when she goes for an X-ray, no calcific tendinitis, no arthritis, so plain frozen shoulder. You give them a glenohumeral cortisone injection. A steroid injection in the glenohumeral joint eliminates frozen shoulder. So it is very well known. And Joe DeBeer, whom I pointed out to you in South Africa, he told me, this is 15 years ago, he told me, you know that classic grafted your toe, inflammatory state, in the freezing state, in the thawing state. If you catch it in the inflammatory state and you give one glenohumeral cortisone injection, the graft stops there. You never go through that phase. They are some of the most grateful patients. So in the inflammatory stage, cortisone injection, physio, invariably they will also tell you, I don't try went to the physio. Guess what, it made it worse. Because the physio is trying to push through the pain barrier and give mobility. Can you imagine somebody's in acute pain and the physios are trying to do stretching exercises? It doesn't work. You can give rest, he'll just continue with frozen shoulder. So glenohumeral cortisone injection is transformational. Once it has established itself, say 6 months down the line, then you have multiple options. You can do a simple MUA or arthroscopy capsular release, which I like to do, is a very simple operation, or hydroadaptation. In the thawing phase, a simple MUA is very useful. You don't need to do anything else. You don't need a capsular release because the inflammation is fast. So just an MUA is good. But in the top phase, you can do hydro capsular release or MUA with capsular release. Does that help you? Anything else? The rest of them are topics in their own right. Cuff repair is, we could be here for 2 hours and not reach a conclusion. If I talk about reverse shoulder replacement, which is my main talk on trauma and elective, then we'll be here all evening. Good. So that finishes the academic discussions. Any other questions?
What if there is calcium tendinitis?
Again, subacromial injection, not clinically. Again, that is transformational. Get an X-ray. When does the calcium tendinitis become painful? When it is liberated out of the cuff. So you may have calcium in your rotator cuff now, and it may be there for 10 more years. But when it gets liberated into the subacromial space, it's a very noxious substance, very toxic substance. It creates an acute inflammatory reaction. You get acute bursitis. It is so bad that people end up in A&E. They either think they're fractured it without trauma, or they think there's pus in the shoulder. That's how bad it is. I have sometimes injected without an X-ray. Without the patient. So you're sitting and your consultant colleague walks in and says, "This is terrible, Shantanu. I don't know what I've done." I said, "Come on, sit down." Under the acromion, give us a subacromial injection. People are horrified. So what about if it's infection? It's not infection. He's not systemically unwell. He has no temperature. He's totally well. It started overnight. There is no trigger for him to have an infection. And it is transformational. Within 48 hours, the pain goes. So you don't do excision of calcium in the acute stage. He will get a frozen shoulder. You sort out the acute phase by a subacromial injection, wait for it. If he gets 2 or 3 attacks a year, and there's a large amount of calcium, take it out after story. That's a lovely operation. It works well.
Which method is preferable for anterior shoulder distribution, or it is generalized as the patient?
Relocating it?
Relocating.
Oh, there is, basically a patient lying down. I put a sheet. I don't do any of that. We are more than any residents will do it. You put a sheet underneath the patient from somebody on the opposite side to stop him coming off. And basically just hold the arm and give straight longitudinal traction. I get the registrar to do that. And if the rare, I'll be sitting next to them in the armpit and slowly beavering it back. I don't do the coccus maneuver anywhere. Coccus maneuver here. Dr. Joshi was telling in the A&E, my God, how many coccus maneuvers we have done. And that's interesting, visual to do, but it's a traumatic maneuver. Hippocrates is bad, putting your, that's very historical. So it's good to know about it. So no coccus, no Hippocrates, just simple longitudinal traction, and keep chatting with the patient. Give them a little bit of sedative or whatever you give here. You give some gas and air, antinox and a bit of propofol if required. If you give propofol, it's cheating because I think the anesthesia is reduced it. There is no skill involved. You might as well sit in the coffee room and ask them to give a really come back. So if you do it without any sedation or something, it is your skill. The problem is when you start doing it, they start coming off this way. So just put a sheet underneath and get someone to put it in. It looks, somebody non-orthopedic walks in the theatre, it looks like a torture. But it's not. Anything else? Shoulder is a lovely topic, so if you ever want to take it up, it's wonderful. Because not many people know much about it, so nobody interferes. Everybody does a bit of carpenter and a bit of scopical shoulder. I do a bit of a hip, nobody does a bit of shoulder. They're scared. And I didn't talk about today. Elbow replacement is also, elbow examination is also a lovely examination. It's a neglected joint. You know, everybody does it, wrist and hand and shoulder, and this sort of is like a country cousin. Anything else? Anybody else wants to ask me anything about opportunities in UK? I can't tell you any opportunities in India. I'm so out of touch. You know this better than I do. All of you are aware? No. Yes? No? No. Do you want to know?
Yes.
So I wouldn't come before MS. And MS is more regarded as D ortho. I don't know what the status of D&D is. I don't think anybody even knows the degree. We know it more in this country. And there are multiple ways of coming. One is PLAB. It's a straightforward way of coming. It's hard work. I think you can give PLAB 1 here now, isn't it?
Yes.
Yeah, PLAB 2 you have to come to the UK. Yeah, so to me, as I said, I think PLAB is a difficult example. I was completely useless in medicine side of medicine. Reading an ECG or auscultating was just hard work. I don't know how I passed my final exam, but somehow managed to get through. So if you have to go through all that and you're happy, then that's great. That's one way. The second option is this ISTP program, International Students Training Program. Just Google that a little bit. I've asked one of my friends to send me some information about it. It's ISTP, International Student Training Program. So we've had a few in our hospital. Basically what you do is you get a 2-year visa to do 4 placements, 6 months each. And we have a group where we have Chesterfield, Derby, Nottingham, Sheffield, and Doncaster. So we have these 5 hospitals in Nottingham. So they go 6 months each, and you can tell which is your preference. We've just had a guy called Dr. Satish, who came from Bangalore, and he's gone back. He texted me a few weeks ago. He has an established practice in Apollo there. So he's doing very well. He spent 6-12 months with us. It depends whom you go to in that. You may not get much assistance. It's a bit of a hit and miss. Because if you go with a boss who gives you a lot of operations to do like me, I love to give operations to people, but then you need a reasonable amount of confidence to do it because it's your responsibility eventually. But some people will just not, even after 6 months, will think, oh my God, I'm doing exactly what I was doing in India. I've actually not done a single hip replacement. All I've done is hold the retractors. I know how to do it, but till you do it, it's like learning swimming without getting in the water. There's no point in knowing all the steps of how to swim front row, back row, except the only thing remaining is getting in the pool. It's not going to work. So it's a bit of a hit and miss. The other is pure fellowships. So I run a fellowship program in our hospital. We have had 9 fellows from all over the world. Our latest fellow has gone back to Auckland in New Zealand, and he's become a consultant there. But we don't give fellowships unless you have experience in UK. So it's a catch-22. Because we can't just get somebody from here and start doing fellowship there because if you have no experience in UK. So PLAB, ISTP, double sponsorship is gone, I think. I don't think double sponsorship scheme exists anymore. Third is just direct fellowships in some places. The fourth way of people are getting in is via Middle East. So if you have actually employed 4 or 5 radiologists directly from Muscat, one of the hospitals. So they understand that a certain cream of India has gone to UAE or Dubai or something, and they've had a few years of experience with overseas people there, and then they get in there. One way of getting in there is receive bad publicity recently. I don't know if you have seen it it's on Facebook and all. One of the Indian consultants, some of them came here via the Royal College, interviewed people it is said under the false promise of becoming a consultant. That is very difficult. That's not an easy job. You have to get into a training program. You must get your FRCS on. Sorry, can I just say, all of you can apply for FRCS on international. That doesn't give you the right to become a consultant, but it gives you a massive uplift here. So there is something called FRCS or international now. So just do a bit of research on that. Go on Royal College websites. So we run courses for them, for FRCS or international. So our last course was in Jordan. The one before that was in Hyderabad, Singapore, Dubai, and this one is in Hong Kong. And all over the world, people come there from Australia, from China, from India, and they're applying directly for FRCS or international. You will have FRCS or INT written in the bracket, because that means you have not gone through a 6-year training program in UK. But you have to tick some boxes that you've done this, you've done this, you've done this, and then you become eligible for it. And the standard is the same in FRCS or pass rate is very poor. Last one was 32%. Awful pass rate. And it's very expensive. I think the total cost including the course will come to between £2,000 or £3,000, I think. So it's an expensive exam, and if you have to give it 2-3 times, we have got one guy, my God, he will not give up. This is his 4th attempt. And he's from Cairo. He will not give up, and he just said at some stage you have to understand, you're not going to pass this exam. But there you go. So these are the various avenues you can look at. But look at ISTP. ISTP at present is probably the easiest training program. And if I get some more information, I will pass it on to Parag, so he can give you information. The program is very structured in the UK. It's very, very structured. So you do 6 months of 1 year of arthroplasty, trauma you do all the time, pediatrics, spine, you don't do tumors, shoulder and elbow, wrist and hand, and you go through the whole program. So it's very, very nice. No other questions? Perfect time for 1 hour. Okay. Well, thank you very much. It's been a pleasure to meet you all, and my best wishes to all.
Thank you very much, sir. And and I think I have got a good insight into shoulder examination, also the opportunities in UK. So, thank you for this opportunity.
Thank you very much. It's a great throwback to come somewhere like this where I was sitting there 30 years ago. Thank you. It's very kind. And we used to have Chit Ranavat. Have you heard of Chit Ranavat? Chit Ranavat? So Chit Ranavat used to come from hospital special surgery in New York, and I think I was here when he did Rishikesh Mukherjee's bilateral knee replacement, and all people from all over used to come to have knee replacement and hips done by him. And he used to give us some real beads of wisdom. And one sentence he said was very interesting. He said, if ever somebody tells you that there's a cemented hip replacement in less than 50 minutes, he's cutting corners. Don't get operated by him. If they say they're taking more than 1.5 hours, they don't know how to do it properly either. Risk of infection is higher. Don't get it done by them either. Stick between 50 minutes and 1.5 hours. That's the right surgeon. And sometimes these things stay in your mind. Speed is not everything. Speed is only useful if you're as good as if you took 10 minutes long. So don't go for speed. Most of the nurses love speedy surgeons. Oh, it's fantastic, I'm going to be in his theatre. I'll go home early. Because he's so fast, he must be good. No, that's not. That's a fallacy. He could be fast and good, but there are very few those like that. So just be careful about that. Good. All the best for your future. Thank you.
Thank you.